Abdominal cavity and peritoneum. Introduction. Abdominal cavity is the largest cavity. It encloses the peritoneal cavity between its parietal and visceral layers. Parietal layer clings to the wall of parieties while visceral layer is intimately adherent to viscera concerned. So their vascular supply and nerve supply are same as the parieties and viscera respectively. There are very lengthy organs in the peritoneal cavity. These had to be disciplined with limited movements for proper functioning of the gut in particular and the body in general. Infections involving the parietal peritoneum impart protective board-like rigidity to the abdominal wall. Referred pain from the viscera to a distant area is due to somatic and sympathetic nerves reaching the same spinal segment. 9 regions of abdomen. For the purpose of describing the location of viscera, the abdomen is divided into 9 regions by 4 imaginary planes, 2 horizontal and 2 vertical. The horizontal planes are the transpyloric and transtubercular planes. The vertical planes are the right mid-clavicular and mid-axillary plane. The transpyloric plane of Addison passes midway between the superior-sternal notch and the pubic symphysis. It lies roughly a hand's breadth below the xiphisternal joint. Anteriorly, it passes through the tips of the 9th costal cartilage, and posteriorly through the body of vertebrae near its lower border. Organs present on this plane are pylorus of stomach, beginning of duodenum, neck of pancreas and hyla of the kidneys. The transtubercular plane passes through the tubercles of the iliac crest and the body of vertebra L5 near its upper border. The right and left lateral planes correspond to the midclavicular or mammary lines. Each of these vertical planes passes through the midinguinal point and crosses the tip of the 9th costal cartilage. The 9 regions marked out in this way are arranged in 3 vertical zones, median, right and left. From above downwards, the median regions are epigastric, umbilical, and hypogastric. The right and left regions, in the same order, are hypochondriac, lumbar and iliac. Position of many organs is mentioned in this table. Liver chiefly occupies the right hypochondrium. Duodenum lies in relation to posterior abdominal wall. Jejunum and ileum fill up the umbilical, lumbar and iliac region. Large intestine lies at the periphery of abdominal cavity. Cecum ascending colon on the right side, descending colon on the left side, and transverse colon across the cavity. Peritoneum. The peritoneum, Greek stretched over, is a large serous membrane lining the abdominal cavity. Histologically, it is composed of an outer layer of fibrous tissue, which gives strength to the membrane, and an inner layer of mesothelial cells which secrete a serous fluid which lubricates the surface, thus allowing free movements of viscera. The peritoneum is in the form of a closed sac which is invaginated by a number of viscera. As a result, the peritoneum is divided into A. An outer or parietal layer, B. An inner or visceral layer, C. Folds of peritoneum by which the viscera are suspended. The peritoneum, which is a simple cavity, before being invaginated by viscera becomes highly complicated. Parietal peritoneum. L. It lines the inner surface of the abdominal and pelvic walls and the lower surface of the diaphragm. It is loosely attached to the walls by extraperitoneal. Embryologically, it is derived from the somatopleuric layer of the lateral plate mesoderm. 2. Its blood supply and nerve supply are the same as those of the overlying body wall. Because of the somatic innervation, parietal peritoneum is pain sensitive. Visceral peritoneum. 2. It lines the outer surface of the viscera, to which it is firmly adherent and cannot be stripped. In fact, it forms a part and parcel of the viscera. 3. Embryologically, it is derived from the splanchnopleuric layer of the lateral plate mesoderm. Its blood supply and nerve supply are the same as those of the underlying viscera. Because of the autonomic innervations, visceral peritoneum evokes pain when viscera is stretched, ischemic or distended. Folds of peritoneum. 1. Many organs within the abdomen are suspended by folds of peritoneum. Such organs are mobile. The degree and direction of mobility are governed by the size and direction of the peritoneal fold. Other organs are fixed and immobile. They rest directly on the posterior abdominal wall, and may be covered by peritoneum on one side. Such organs are said to be retroperitoneal, Table 18.2. Some organs are suspended by peritoneal folds in early embryonic life, but later become retroperitoneal. Apart from allowing mobility, the peritoneal folds provide pathways for passage of vessels, nerves, and lymphatics. Two peritoneal folds are given various names. In general, the name of the fold is made up of the prefix mes or meso followed by the name of the organ, e.g. the fold suspending the small intestine or enteron is called the mesenter, and a fold suspending part of the colon is called meso-6-enlon. Large peritoneal folds attached to the stomach are called omentum, singular of which is omentum, which means cover. In many situations double-layered folds of peritoneum connect organs to the abdominal wall or each other. Such folds are called ligaments. These may be named after the structures they connect. For example, the gastrosplenic ligament connects the stomach to the spleen. Other folds are named according to their shape, e.g. the triangular ligaments of the liver. Some of the larger peritoneal folds are considered in this chapter, while others are considered along with the organs concerned. Peritoneal cavity. The viscera which invaginate the peritoneal cavity completely fill it so that the cavity is reduced to a potential space separating adjacent layers of peritoneum. Between these layers there is a thin film of serous fluid secreted by the mesothelial cells. This fluid performs a lubricating function and allows free movement of one peritoneal surface over another. Under abnormal circumstances there may be collection of fluid called a syphs, or of blood called hemoperitoneum, or of air called pneumoperitoneum within the peritoneal cavity. The peritoneal cavity is divided broadly into two parts. The main, larger part is known as the greater sac, and the smaller part, situated behind the stomach, the lesser omentum and the liver, is known as the omental bursa or lesser sae. The two sacs communicate with each other through the epiploic foramen of Winslow or opening into the lesser sac. Small pockets or recesses of the peritoneal cavity may be separated from the main cavity by small folds of peritoneum. These peritoneal recesses or fossae are of clinical importance. Internal hernia may take place into these recesses. Sex differences. In the male, the peritoneum is a closed sac lined by mesothelium or flattened epithelium. The female peritoneum has the following distinguishing features. The peritoneal cavity communicates with the exterior through the uterine tubes. 1. The peritoneum covering the ovaries is lined by cubical epithelium. 2. The peritoneum covering the limbaria is lined by columnar ciliated epithelium. Functions of peritoneum. 1. Movements of viscera. The chief function of the peritoneum is to provide a slippery surface for free movements of abdominal viscera. This permits peristaltic movements of the stomach and intestine, abdominal movements during respiration and periodic changes in the capacity of hollow viscera associated with their filling and evacuation. The efficiency of the intestines is greatly increased as a result of the wide range of mobility that is possible because the intestines are suspended by large folds of peritoneum. 2. Protection of viscera. The peritoneum contains various phagocytic cells which guard against infection. Lymphocytes present in normal peritoneal fluid provide both cellular and humoral immunological defense mechanisms. The greater omentum has the power to move towards sites of infection and to seal them, thus preventing spread of infection. For this reason the greater omentum is often designated as the policeman of the abdomen. 3. Absorption and dialysis. The mesothelium acts as a semi-permeable membrane across which fluids and small molecules of various solutes can pass. Thus, the peritoneum can absorb fluid effusions from the peritoneal cavity. Water and crystalloids are absorbed directly into the blood capillaries, whereas colloids pass into lymphatics with the aid of phagocytes. The greater absorptive power of the upper abdomen or subphrenic area is due to its larger surface area and because respiratory movements aid absorption. Therapeutically, considerable volumes of fluid can be administered through the peritoneal route. Conversely, metabolites, like urea, can be removed from the blood by artificially circulating fluid through the peritoneal cavity. This procedure is called peritoneal dialysis. For healing power and adhesions, the mesothelial cells of the peritoneum can transform into fibroblasts which promote healing of wounds. They may also form abnormal adhesions causing obstruction in hollow organs. Storage of fat. Peritoneal folds are capable of storing large amounts of fat, particularly in obese persons. Collection of free fluid in the peritoneal cavity is known as a syphs. Common causes of ascites are cirrhosis of the liver, tubercular peritonitis, congestive heart failure, and malignant infiltration of the peritoneum. Veins also get prominent in cirrhosis of liver. Fluid from the peritoneal cavity may be removed by puncturing the abdominal wall either in the median plane midway between the umbilicus and pubic symphysis, or at a point just above the anterior superior iliac spine. The procedure is called paracentesis. Urinary bladder must be emptied before the procedure, Fig 18.4. Inflammation of the peritoneum is called peritonitis. It may be localized when a subjacent organ is infected, or may be generalized. The latter is a very serious condition. The presence of air in the peritoneal cavity is called pneumoperilanoon. It may occur after perforation of the stomach or intestines. Laparoscopy is the examination of the peritoneal cavity under direct vision using an instrument called laparoscope. Opening up the abdominal cavity by a surgeon is called laparotomy. Greater omentum limits the spread of infection by sealing off the site of ruptured vermiform appendix or gastric ulcer and tries to delay the onset of peritonitis. It is called abdominal policeman. Inflammation of parietal peritoneum causes localized severe pain and rebound tenderness on removing the fingers. Peritoneal dialysis is done in case of renal failure. The procedure removes the urea, etc. as it diffuses through blood vessels into the peritoneal cavity. Dissection. Expose the extensive abdominal cavity by reflecting anterior abdominal wall into 4 flaps, 2, right and left, above and 2 below the umbilicus. Identify the peritoneum. Divide and reflect it with the anterior abdominal wall. Cut the fold of peritoneum which passes from the median part of the supra-umbilical part of the anterior abdominal wall to the liver, known as the falciform ligament. This fold contains the ligamentum teres of the liver or the obliterated left umbilical vein in its free posterior border. Examine the posterior surface of the reflected lower parts of anterior abdominal wall. Identify 5 ill-defined peritoneal folds which pass upwards, Fig 18.19, towards the umbilicus. These are 2 lateral, 2 medial, and 1 median umbilical folds. Identify the parietal peritoneum, adherent to the parieties or walls of the abdominal cavity. Trace it from the walls to form various double-layered folds which spread out to enclose the viscera as the visceral peritoneum. Identify and lift up the greater omentum. See its continuity with the stomach above and the transverse colon fused with its posterior surface a short distance inferior to the stomach. Cut through the anterior layers of the greater omentum 2-3 cm inferior to the arteries to open the lower part of the omental bursa sufficiently to admit a hand. Explore the bursa. Pull the liver superiorly and lift its inferior margin anteriorly to expose the lesser omentum. Examine the right free margin of lesser omentum, containing the bile duct, proper hepatic artery and portal vein. This free margin forms the anterior boundary of the opening into the lesser sac, i.e. epiploic foramen. The posterior boundary is the inferior vena cava. Superior to opening into the lesser sac is the caudate process of liver and inferiorly is the first part of duodenum. Remove the anterior layer of peritoneum from the lesser omentum along the lesser curvature of the stomach. Find and trace the left gastric vessels along the lesser curvature of stomach. Trace the esophageal branches to the esophagus. Trace the right gastric artery to the proper hepatic artery and the vein to the portal vein. Expose the proper hepatic artery and trace its branches to the porta hepatis. Trace the cystic duct from the gallbladder. Follow the common hepatic duct to the porta hepatis and the bile duct till it passes posterior to the duodenum features. The folds can be best understood by recapitulating the embryology of the gut. The developing gut is divisible into 3 parts, foregut, midgut, and hindgut. Each part has its own artery which is a ventral branch of the abdominal aorta. The coeliac artery supplies the foregut, the superior mesenteric artery supplies the midgut, and the inferior mesenteric artery supplies the hindgut. Apart from some other structures, the foregut forms the esophagus, the stomach, and the upper part of the duodenum up to the opening of the bile duct. The midget forms the rest of the duodenum, the jejunum, the ileum, the appendix, the cecum, the ascending colon, and the right 2/3 of the transverse colon. The hindgut forms the left 1/3 of the transverse colon, the descending colon, the sigmoid colon, proximal part of the rectum. The anorectal canal forms distal part of rectum and the upper part of the anal canal up to the pectinate line. The abdominal part of the foregut is suspended by mesenteries both ventrally and dorsally. The ventral mesentery of the uregut is called the ventral mesogastrium. And dorsal mesentery is called dorsal mesogastrium. The ventral mesogastrium becomes divided by the developing liver into a ventral part and a dorsal part. The ventral part forms the ligaments of the liver, namely, A. The falciform, Latin sickle-shaped, ligament. B. Right and left triangular ligament. C. The superior and inferior layers of coronary. D. Ligament. The dorsal part of the ventral mesogastrium forms the lesser omentum. The fate of dorsal mesogastrium is follow. A. The greater or caudal part of the dorsal mesogastrium becomes greatly elongated and forms the greater omentum. B. The spleen develops in relation to the cranial part of the dorsal mesogastrium, and divides it into dorsal and ventral parts. The ventral part forms the gastrosplenic ligament while the dorsal part forms the lienorenal ligament. C. The cranial most part of the dorsal mesogastrium form the gastrophrenic ligament. The midst and hindst have only a dorsal mesentery, which forms the mesentery of jejunum and ileum, the mesoappendix, the transverse mesocolon and the sigmoid mesocolon. The mesenteries of the duodenum, the ascending colon, the descending colon and the rectum are lost during development. Greater omentum. The greater omentum, Latin apron, is a large fold of peritoneum which hangs down from the greater curvature of the stomach like an apron and covers the loops of intestines to a varying extent. It is made up of 4 layers of peritoneum, all of which are fused together to form a thin enestrated membrane containing variable quantities of fat and small arteries and veins. Attachments. The anterior 2 layers descend from the greater curvature of the stomach to a variable extent, and fold upon themselves to form the posterior 2 layers which ascend to the anterior surface of the head, and the anterior border of the body of the pancreas. The folding of the omentum is such that the first layer becomes the 4th layer and the second layer becomes the 3rd layer. In its upper part, the 4th layer is partially fused to the anterior surface of the transverse colon and of the transverse mesocolon. The part of the peritoneal cavity called the lesser sac between the 2nd and 3rd layers gets obliterated, except for about 2.5 cm below the greater curvature of the stomach. Contents. 1. The right and left gastroepiploic vessels anastomose with each other in the interval between the first 2 layers of the greater omentum a little below the greater curvature of the stomach. Functions. It is a storehouse of fat. 1. It protects the peritoneal cavity against infection because of the presence of macrophages in it. Collections of macrophages form small, dense patches, known as milky spots, which are visible to the naked eye. 2. It also limits the spread of infection by moving to the site of infection and sealing it off from the surrounding areas. On this account, the greater omentum is also known as the policeman of the abdomen. The greater omentum forms a partition between the supracolic and infracolic compartments of the greater sac. Lesser omentum, mesentery, and dissection. Appendix. Remove the remains of the lesser omentum leaving the vessels and duct intact and examine the abdominal wall posterior to the omentum and the omental bursa. Turn the small intestine to the left. Cut through the right layer of peritoneum of the mesentery along the line of its attachment to the posterior abdominal wall and strip it from the mesentery. Remove the fat from the mesentery to expose the superior mesenteric vessels in its root and their branches and tributaries in the mesentery. Trace the superior mesenteric vessels proximally and distally. Dissect the branches to the jejunum, ileum, cecum, appendix, ascending colon, right 2/3 of transverse colon, the distal part of duodenum and pancreas. Turn the small intestine and its mesentery to the right. Remove the peritoneum and fat on the posterior abdominal wall between the mesentery and descending colon to expose the inferior mesenteric vessels and the autonomic nerves and lymph nodes associated with them. Turn the cecum upwards and uncover the structures posterior to it. Trace the 3 tenyi on the external surface of the colon and cranial to the root of the vermiform appendix. Lesser omentum. This is a fold of peritoneum which extends from the lesser curvature of the stomach and the first 2 cm of the duodenum to the liver. The portion of the lesser omentum between the stomach and the liver is called the hepatogastric ligament, and the portion between the duodenum and the liver is called the hepatoduodenal ligament. Behind the lesser omentum there lies a part of the lesser sac. The lesser omentum has a free right margin behind which there is the epiploic foramen. The greater and lesser sacs communicate through this foramen. Attachments. Inferiorly, the lesser omentum is attached to the lesser curvature of the stomach and to the upper border of the first 2 cm of the duodenum. Superiorly, it is attached to the liver, the line of attachment being in the form of an inverted L. The vertical limb of the L is attached to the bottom of the fissure for the ligamentum venosum, and the horizontal limb to the margins of the porta hepatis. Contents. The right free margin of the lesser omentum contain, 1. The proper hepatic artery. 2. The portal vein. 3. The bile duct. 4. Lymph nodes and lymphatics. 5. The hepatic plexus of nerves, all enclosed in a perivascular fibrous sheath. Along the lesser curvature of the stomach and along the upper border of the adjoining part of the duodenum it contains, 1. Right gastric vessels. 2. The left gastric vessels. 1. The gastric group of lymph nodes and lymphatics, and branches from the gastric nerves. Mesentery. The mesentery, Greek fold of intestine, of the small intestine or mesentery proper is a broad, fan-shaped fold of peritoneum which suspends the coils of jejunum and ileum from the posterior abdominal wall. Border. The attached border, or root of the mesentery, is 15 cm long, and is directed obliquely downwards and to the right. It extends from the duodenojejunal flexure on the left side of vertebra L2 to the upper part of right sacroiliac joint. It crosses the following structures: 1. The third part of the duodenum where the superior mesenteric vessels enter into it. 2. The abdominal aorta. 3. The inferior vena cava. 4. The right ureter. 5. The right psoas major. The free or intestinal border is 6 meters long, and is thrown into pleats. It is attached to the gut, forming its visceral peritoneum or serous coat. The breadth of the mesentery is maximum and is about 20 cm in the central part, but gradually diminishes towards both the ends. Distribution of fat. Fat is most abundant in the lower part of the mesentery, extending from the root to the intestinal border. The upper part of the mesentery contains less fat, which tends to accumulate near the root. Near the intestinal border it leaves oval or circular fat-free, translucent areas. Contents. The contents of the mesentery are, 1. Jejunal and ileal branches of the superior mesenteric artery, 2. Accompanying veins, 3. Autonomic nerve plexuses, 4. Lymphatics or lacteals, 5. 100-200 lymph nodes, and connective tissue with fat. Mesoappendix. It is a small, triangular fold of peritoneum which suspends the vermiform appendix from the posterior surface of the lower end of the mesentery close to the iliacecal junction. Usually the fold extends up to the tip of the appendix, but sometimes it fails to reach the distal 1/3 or so. It contains vessels, nerves, 1 ymph nodes, and lymphatics of the appendix. Dissection. Expose the anterior border of the pancreas and define the attachments of the transverse mesocolon. Trace the duodenum from the pylorus to the duodenojejunal flexure. Features. This is a broad fold of peritoneum which suspends the transverse colon from the upper part of the posterior abdominal wall. Attachments. The root of the transverse mesocolon is attached to the anterior surface of the head, and the anterior border of the body of the pancreas. The line of attachment is horizontal with an upward inclination towards the left. Contents. It contains the middle colic vessels, the nerves, lymph nodes, and lymphatics of the transverse colon. Sigmoid mesocolon. Dissection. Trace the fold of peritoneum from the upper half of left external iliac artery to the termination of left common iliac artery and then downwards till the third piece of sacrum. Features. This is a triangular, Greek S-shape, fold of peritoneum which suspends the sigmoid colon from the pelvic wall. Attachment. The root is shaped like an inverted V. Its apex lies over the left ureter at the termination of the left common iliac artery. The left limb of V is attached along the upper half of the left external iliac artery, and the right limb to the posterior pelvic wall extending downwards and medially from the apex to the median plane at the level of vertebra S3. Contents. The sigmoid vessels in the left limb, superior rectal vessels, nerves, lymph nodes, and lymphatics in the right limb of the sigmoid colon. Reflection of peritoneum on the liver. It can be seen that on reaching the liver, the peritoneum forming the two layers of the lesser omentum passes onto the surface of the liver. After lining the surfaces of the liver, this peritoneum is reflected onto the diaphragm and to the anterior abdominal wall in the form of a number of ligaments. These are the falciform ligament, the left triangular ligament, the coronary ligaments and the right triangular ligament. The falciform ligament is described below. The other ligaments are described later along with the liver. The falciform ligament is a sickle-shaped fold of peritoneum which connects the anterosuperior surface of the liver to the anterior abdominal wall and to the undersurface of the diaphragm. This fold is raised by the ligamentum teres of the liver. The ligamentum teres extends from the umbilicus to the inferior border and inferior surface of the liver. It joins the left branch of the portal vein, at the left end of the porta hepatis, to the ligamentum venosum, Fig 18.16. Peritoneal cavity. The layout of the greater sac can be studied by tracing the peritoneum both vertically and horizontally. Vertical tracing or sagittal tracing. 1 Peritoneum lining the anterior abdominal wall and diaphragm, first layer. 2 Peritoneum lining upper part of posterior abdominal wall and diaphragm, third layer. 3 The first and second layers enclose most of the liver. The 2 layers get reflected at porta hepatis to form the lesser omentum. 4 Lesser omentum encloses the stomach and 2 layers pass downwards as greater omentum, where these fold upon themselves. First layer becomes fourth layer and second layer becomes the third layer. 5 Third and fourth layers enclose transverse colon to continue as transverse mesocolon. 6 Third layer lines the structures in the upper part of posterior abdominal wall. 7 The fourth layer passes around the small intestine to form the mesentery of small intestine. 8 Peritoneum lines the structures in the posterior abdominal wall and descends into the true pelvis in front of the rectum. The subsequent tracing is different in the male and in the female. 9 In the male, the peritoneum passes from the front of rectum to the urinary bladder, forming rectovesical pouch. In the female, it passes from the front of rectum to the uterus forming rectouterine pouch and from the uterus to the urinary bladder forming the vesicouterine pouch. Figs 18.17a and b, a, sagittal section through the abdomen, male, to show the reflections of peritoneum, and, b, sagittal section through a female pelvis showing the peritoneal reflections both in the male and female. The peritoneum passes from the urinary bladder to the anterior abdominal wall, thus completing the sagittal tracing of the peritoneum. Lesser sac is bound in front by, a. the posterior layer of lesser omentum. A. the peritoneum lining the posterior surface of the stomach. B. first and second layer of greater omentum. Lesser sac is bounded behind by third and fourth layers of the greater omentum and the peritoneum lining the upper part of the posterior abdominal wall. Horizontal tracing above transverse colon. Falciform ligament from the anterior abdominal wall encloses the liver. At porta hepatis it forms lesser omentum which encloses the stomach. The 2 layers pass to left towards spleen as gastrosplenic ligament. At the hilum, the 2 layers of gastrosplenic ligament diverge. The anterior layer encloses the spleen, forms 1 layer of lienorenal ligament, covers left kidney and continues to line the structures in the anterior abdominal wall, Fig 18.18. The posterior layer forms the other layer of lienorenal ligament and lines the structures in the posterior abdominal wall. The 2 layers get reflected as falciform ligament on the liver. Horizontal tracing below the level of the transverse colon. On the back of the anterior abdominal wall we see a number of peritoneal folds, and fossae, Fig 18.19. Starting from the median plane, these are: L, the median umbilical fold raised by the median umbilical ligament, remnant of the urachus. 2, the medial inguinal ligament. 2, the medial umbilical fold raised by the obliterated umbilical artery. 3, the lateral inguinal fossa. 4, the lateral umbilical fold raised by the inferior epigastric vessels. 5, the femoral fossa overlying the femoral septum. Further laterally, the peritoneum passes over the lateral part of abdominal wall to reach the posterior abdominal wall. Near the middle, the peritoneum becomes continuous with the 2 layers of the mesentery and thus reaches the small intestine. At this level we also see the greater omentum made up of 4 layers. It lies between the intestines and the anterior abdominal wall. Horizontal tracing of peritoneum in the lesser pelvis, male. In Fig 18.20 note the following. 1, the rectovesical pouch. 2, the pararectal fossae. 3, the sacrogenital folds forming the lateral limit of the rectovesical pouch. 4, the pararectal fossae. 5, the paravesical fossae. The sigmoid colon and mesocolon are present, but are not shown in the diagram. Horizontal tracing of peritoneum in the lesser pelvis, female. In Fig 18.21 note the following. 1, the uterus and the broad ligaments form a transverse partition across the pelvis. 2, the pararectal and paravesical fossae. 3, the rectouterine pouch. 4, the mesovarium by which the ovary is suspended from the posterior, superior, layer of the broad ligament. Epiploic foramen, synonyms: Epiploic foramen, foramen of Winslow, Adidas, or opening to the lesser sac. This is a vertical slit-like opening through which the lesser sac communicates with the greater sac. The foramen is situated behind the right free margin of the lesser omentum at the level of the 12th thoracic vertebra. Boundaries. Anteriorly, right free margin of the lesser omentum containing the portal vein, proper hepatic artery, and the bile duct. Posteriorly, the inferior vena cava, the right suprarenal gland, and T12 superiorly, caudate process of the liver. Inferiorly, first part 01, the duodenum and the horizontal part of the hepatic artery. Lesser sac or omental bursa, this is a large recess of the peritoneal cavity behind the stomach, the lesser omentum and the caudate lobe of the liver. It is closed all around, except in the upper part of its right border where it communicates with the greater sac through the epiploic foramen. Boundaries of lesser sac: anterior 1, peritoneum covering caudate lobe and caudate process of liver. 2, posterior layer of lesser omentum. 3, perioneum covering posterior surface of stomach. 4, second layer of greater omentum. Posterior, third layer of greater omentum. Peritoneum covering anterosuperior surface of transverse colon, upper layer of transverse mesocolon. Peritoneum covering the anterior surface of body of pancreas, left suprarenal, left kidney, splenic vessels and diaphragm. Upper reflection of peritoneum from diaphragm to liver, lower right margin of greater omentum. Reflection of peritoneum from neck of pancreas to LST part of duodenum. Right epiploic foramen, peritoneal reflection from diaphragm to caudate lobe. 1, strangulated internal hernia into the lesser sac through epiploic foramen is approached through the greater omentum because the epiploic foramen cannot be enlarged due to the presence of important structures all around it. Peritonides parietal peritoneum of abdomen is supplied by T7, T12 and L1. While that of the pelvis is supplied by the obturator nerve. Peritonitis may caused by A, by an opening in the closed gastrointestinal tract in abdominal cavity, by ruptured appendix or gastric ulcer perforation or typhoid ulcer perforation. B, infection by any opening through anterior abdominal wall. C, infection through vagina, through uterine cavity, fallopian tube to reach the peritoneal cavity. Special regions of the peritoneal cavity. From a surgical point of view, the peritoneal cavity has 2 main parts, the abdomen proper and the pelvic cavity. The abdominal cavity is divided by the transverse colon and the transverse mesocolon into the supracolic and infracolic compartments. The supracolic compartment is subdivided by the reflection of peritoneum around the liver into a number of subphrenic spaces. The infracolic compartment is also subdivided, by the mesentery, into right and left parts. Further, the right porocolic gutter lies along the lateral side of the ascending colon, and the full porocolic gutter along the lateral side of the descending colon, Fig 18.27. 2. Development. 3.1 Right pneumoenteric recess in the right wall of dorsal mesogastrium grows to form the greater part of the lesser sac, except for the vestibule. Vestibule develops from the general peritoneal cavity lying behind the lesser omentum after the rotation of stomach. Supracolic compartment / subphrenic spaces. Subphrenic spaces are present just below the diaphragm in relation to the liver, Fig 18.27. Classification. The intraperitoneal spaces are, 1. The left anterior space. 2. The left posterior space. 3. The right anterior space. 4. The right posterior space. The extraperitoneal spaces include, the right extraperitoneal space and left extraperitoneal space. 1. Midline extraperitoneal space is the name given to bare area of liver. Some details of these spaces are as follows. The left anterior space or the left subphrenic space lies between the left lobe of the liver and the diaphragm, in front of the left triangular ligament. Inferiorly, it extends to the front of the lesser omentum and of the stomach. Towards the left it reaches the spleen. An abscess may form in this space following operations on the stomach, the spleen, the splenic flexure of the colon, and the tail of the pancreas. The left post-orular space or the left sub-hepatic space is merely the lesser sac which has already been described. The right anterior space or right subphrenic space lies between the right lobe of the liver and the diaphragm, in front of the superior layer of the coronary ligament and the right triangular ligament. Infection may spread to this space from the gallbladder, or the vermiform appendix, or may follow operations on the upper abdomen. The right posterior space or right subhepatic space. The left extraperitoneal space lies around the left suprarenal gland and the upper pole of the left kidney. This is the site for a left perinephric abscess. The right extraperitoneal space lies around upper pole of right kidney. The midline extraperitoneal space corresponds to the bare area of the liver. It lies between the bare area and the diaphragm. It is bounded above and below by the superior and interior layers of the coronary ligament. Infection can spread to this space from the liver, resulting in liver abscess. Hepatornal pouch. Boundaries. Anteriorly, 1. The inferior surface of the right lobe of the liver. 2. The gallbladder. Posteriorly, 1. The right suprarenal gland. 2. The upper part of the right kidney. 3. The second part of the duodenum. 4. The hepatic flexure of the colon. 5. The transverse mesocolon. 6. A part of the head of the pancreas. Superiorly, the inferior layer of the coronary ligament. Inferiorly, it opens into the general peritoneal cavity. Left, communicate with omental bursa. Right, limited by diaphragm infracolic compartments. Right infracolic compartment. It lies between the ascending colon and the mesentery, below the transverse mesocolon. It is triangular in shape with its apex directed downwards. Left infracolic compartment. It lies between the descending colon and the mesentery. It is also triangular with its apex directed upwards. Inferiorly, it opens freely into the pelvis. Porocolic gutters. The right lateral porocolic gutter opens freely into the hepatornal pouch at its upper end. It may be infected by a downward spread of infection from the hepatornal pouch or from the lesser sac, or by an upward spread from the appendix. The left lateral porocolic gutter opens freely into the pelvis at its lower end. Above it is separated from the spleen and from the lienorenal space by the phrenicochilic ligament. It may be infected from the supracolic compartment, or by an upward spread of infection from the pelvis. Rectouterine pouch of Douglas. This is the most dependent part of the peritoneal cavity when the body is in the upright position. In the supine position, it is the most dependent part of the pelvic cavity. Boundaries. Anteriorly, by the uterus and the posterior fornix of the vagina. Posteriorly, by the rectum. Inferiorly, floor, by the rectovaginal fold of peritoneum. Intraperitoneal subphrenic spaces may get distended by collection of pus. These are called subphrenic abscesses. Hepatorenal space is of considerable importance as it is the most dependent, lowest, part of the abdominal cavity proper when the body is supine. Fluids tend to collect here. This is the commonest site of a subphrenic abscess, which may be caused by spread of infection from the gallbladder, the appendix, or other organs in the region. The floor of the rectouterine pouch is 5.5 centimeters from the anus, and can be easily felt with a finger passed through the rectum or the vagina. The corresponding rectovesical pouch in males lies 7.5 centimeters above the anus. Being the most dependent part of the peritoneal cavity, pus tend to collect here. The infected fluid collects mostly in subphrenic space, especially the hepatorenal pouch, as it is deepest when person is lying supine. If patient sits in inclined position, the infected material tracks down to rectouterine pouch in female or to rectovesical pouch in male. These are small pockets of the peritoneal cavity enclosed by small, inconstant folds of peritoneum. They commonly occur at the transitional zones between the absorbed and unabsorbed parts of the mesentery. These are best observed in foetuses, and are mostly obliterated in adults. Sometimes they persist to form potential sites for internal hernia and their strangulation. Classification. Lesser sac. The lesser sac is the largest recess. It is always present, and has been described earlier. Duodenal fossa or recess 1. The superior duodenal recess is present in about 50% of subjects. It is situated at the level of vertebra L2. It is about 2 centimeters deep. Its orifice looks downwards, Fig 18.32. 2. The inferior duodenal recess is present in about 75% of subjects. It is situated at the level of vertebra L3. It is about 3 centimeters deep. Its orifice looks upwards. 3. The paraduodenal recess is present in about 20% of subjects. The inferior mesenteric vein lies in the free edge of the peritoneal fold. Its orifice looks to the right. 4. The retroduodenal recess is present occasionally. It is the largest of the duodenal recesses. It is 8 to 10 centimeters deep. Its orifice looks to the left. 5. The duodenojejunal or mesocolic recess is present in about 20% of subjects. It is about 3 centimeters deep. Its orifice looks downwards and to the right. 6. The mesenterico-parietal fossa of Waldeyra is present in about 1% of subjects. It lies behind the upper part of the mesentery. Its orifice looks to the left. The superior mesenteric vessels lie in the fold of peritoneum covering this fossa. Cecal fossae. 1. The superior iliacecal recess is quite commonly present. It is formed by a vascular fold present between the ilium and the ascending colon. Its orifice looks downwards and to the left. 2. The inferior iliacecal recess is covered by the bloodless fold of Treves. The orifice of the recess looks downwards and to the left. 3. The retrocecal recess lies behind the cecum. It often contains the appendix. Its orifice looks downwards. The intersigmoid recess. This recess is constantly present in the foetus and in early infancy, but may disappear with age. It lies behind the apex of the sigmoid mesocolon. Its orifice looks downwards. Internal hernia may occur in the opening of lesser sac. It may also occur in between paraduodenal recesses. One has to remember the inferior mesenteric vein in the paraduodenal fold during reduction of the hernia. Pain of foregut-derived structures is felt in the epigastric area. Pain of midgut-derived structures is felt in the periumbilical area. Pain of hindgut-derived structures is left in the suprapubic area. Palpation of the abdominal viscera is done when the patient is in supine position, and the hip and knee are flexed. In extended position, fascia lata of thigh exerts a pull on the inguinal ligament, making palpation difficult. Development. The primitive gut is formed by incorporation of secondary yolk sac into the embryo. The gut is divided into the following. 1. Pharyngeal gut, from buccopharyngeal membrane to tracheobronchial diverticulum. Its derivatives have been dealt in Volume 3. 2. Foregut situated caudal to pharyngeal gut till the origin of hepatic bud. 3. Midgut extends from origin to hepatic bud downwards. Its terminal point is the junction of right 2/3 and left 1/3 of transverse colon of adult. It communicates with the yolk sac. 4 hindgut spans between the end of midgut and the cloacal membrane. Dorsal mesentery is double fold of peritoneum connecting the caudal part of foregut, midgut and most of the hindgut to the posterior abdominal wall. It is subdivided into mesogastrium and mesoduodenum for foregut, into dorsal mesentery proper for jejunum and ileum, and mesentery of vermiform appendix, transverse and pelvic mesocolons for large intestine. Ventral mesentery only exists ventral to the foregut. It is a derivative of the septum transversum. Derivatives of central mesogastrium, lesser omentum falsiform ligament coronary ligaments triangular ligaments derivatives of dorsal mesogastrium, greater omentum. Lienorenal ligament. Gastrophrenic ligament. Gastrosplenic ligament. There are 9 regions of the abdominal cavity. These are right and left hypochondrium and middle epigastrium in upper part. In middle part are right and left lumbar and middle umbilical regions. In the lower part are right and left iliac fossa and middle hypogastrium. Abdominal part of foregut has a dorsal and ventral mesentery each. Midgut and hindguts have only the dorsal mesenteries each. Lesser sac with its fluid prevents compression of most of the posterior abdominal organs by the full stomach. Rectouterine pouch in female is 5.5 cm from surface of perineal skin. Rectovesical pouch in male is 7.5 cm away from the peroneal skin. Peritoneal recess are mostly present at the junction of intraperitoneal and retroperitoneal organs. Right posterior subphrenic space or Morrison's pouch is the deepest pouch in laying position. Spleen-forming stomach bed is separated from stomach by the cavity of greater SAE. Other organs forming bed are separated from stomach by lesser sac.